A 38 years old, right hand dominant musician present in the office 4 days following a laceration on the volar aspect of the right long finger, sustained after a fall onto a broken piece of glass. He complains of pain in the right long digit with inability to flex the finger. He also noted decreased sensations along the other aspect of the finger. He had been working prior to the accident and wished to return to playback guitar. He denied any past medical history but did admit that he has smoked one pack of cigarettes a day. He has been seen previously in local emergency room where his laceration was irrigated and loosely sutured. Tetanus booster was given and IV antibiotics were administered. He was discharged with a protective splint. When you go in for examination, oblique volar laceration is noted, beginning radially, just proximal to the proximal interphalangeal joint, extending ulnarly and distally 1 centimeter to the mid-axial line of the right long finger. The patient demonstrated no active flexion of the proximal interphalangeal joint or distal interphalangeal joint. His 2-point discrimination was greater than 15 millimeter along the ulnar border of the digit. The digit was warm and had good color, turgor, and normal capillary fill. A AP and lateral radiograph was already done in E&E and ensured no bony injury is overlooked, and also to investigate for possible retained body. No fracture was appreciated at that time. In the differential diagnosis, laceration of both flexor digitorum superficialis and profundus and digital nerve is one of the primary one. Laceration of either of the flexor tendon with inability to move secondary to pain is one other factor. No tendon laceration but unable to move secondary to the pain is third differential, and a fourth can be no nerve laceration but rather contused or neuropraxic nerve. A diagnosis was made of laceration of ring flexor digitorum profundus as well as superficialis, along with other digital nerve injury to the ring finger. The repair of lacerated flexor tendon of the hand and their functional return is one of the most difficult and challenging tasks for a surgeon to undertake. Laceration within zone 2 is especially complex. Within this area, fibro-osseous tunnels, digital canals, profundus and superficialis tendon interweave is an intricate relationship and needs to be taken care of. Even minimal swelling of the epitendon is sufficient to impair free motion of both tendons. The margin for error in tendon repair is thus very small in this region. Not the repair itself, but minimizing adhesion is a daunting charge and a challenge. On the one hand, it requires non-traumatic treatment of the tendons, respecting the dorsally located blood supply, and on the other hand require early motion jeopardizing the continuity of the sutures. The patient flexor tendons were repaired with the Tajami technique with 4-stranded 4-0 polyester crossing the repair. Care was taken to avoid excessive handling of the tendons, with the tendon being grasped by forceps only once. Additionally, 6-0 proline running epitendinous sutures were used to minimize gapping and facilitate healing. The sheath was not repaired. No publication to date provides scientific evidence that sheath repair improves the outcome, although one may argue that reconstituting the sheath provides a barrier to adhesion formation, restore synovial fluid nutrition, and restore sheath mechanics. In practicality, the synovial membrane are usually badly damaged and unsalvageable. Gapping at the repair site results in weakening and potentially adhesion formation. Each increase in suture caliber strengthens the repair, nevertheless at the cost of additional material interference. This additional material may compromise tendon vascularity and or precipitate adhesion formation. Biomechanically, coarse sutures placed dorsally strengthen the repair. Yet, There is a fine line as suture placed too dorsally may compromise the tendon blood supply. Early motion should be begun. Stretch tendon healed faster, gain tensile strength faster, form fewer adhesions, and demonstrate better excursion. The surgeon must feel comfortable with his choice of technique and suture material. These characteristics should lend themselves to easy placement of suture in the tendon and ability to place secure knots, affording minimal interference with the tendon vascularity and gapping at the repair site, and provide sufficient strength throughout healing to permit the application of early motion stress to the tendon. While assessing the tensile strength on normally repaired flexor tendon, passive motion gives a strength of 500 grams. Light grip is 1500 grams, strong grip is 5000 grams, and tip pinch of the index finger flexor digitorum profundus is 9000 grams. Preoperative management should include irrigation with 1 liter of normal saline. A tetanus booster should be administered. The cellular laceration is loose proximally and closed with 4-0 nylon suture. In an interrupted fashion, the hand was immobilized with a volary placed splint, maintaining the resting 45 degree of extension, metacarpophalangeal joint near 9 degree of flexion, with full extension of proximal interphalangeal and distal interphalangeal joints. The surgical management is as under. The arm is accentuated with a Ishmael bandage and tourniquet inflated 250 mm Hg. The use of 2 to 4 power loop magnification greatly enhances one's proficiency in performing flexor tendon repair, and small precise infiltration is prerequisite for this type of surgical repair, as is necessary with every tendon laceration repair. The wound is extended in a burr type of fashion, both proximally and distally, to provide a wide visibility of injured area. Using mid-axial extensions, place the digit vessels and nerves at unnecessary risk unless concomitant injury is suspected. The incisions are extended as needed to visualize the lacerated ends of the tendons or tendon. An adequate view of the surgical feat must be created to avoid carrying out delicate surgical repair within the confines of a small cosmetic wound. Dissection begins midline over the tendon sheath and then proceeds with the identification of digital nerves and vessels. If these structures too have been severed, the ends are mobilized and brought into proximity for subsequent suturing. At this point, the laceration in the tendon sheath was identified at a level of C1 level, that is between A2 and A3. A window in the cruciate sheath system is made by carefully excising this tissue. Additional windows can be necessary depending on the level of injury and positioning of the proximal and distal stumps. These should be fashioned as needed. However, great care should be taken to preserve annular component, that is A2 and A4 pulley, which are almost impossible to adequately repair. A distal stump of the profundus and superficialis are delivered into the cruciate window by acutely flexing the DIP and PIP joints. Once the tendons are exposed in this manner, core sutures are placed in superficialis and profundus and clamped for later usage. Retrieving of the proximal stump may be difficult, and several techniques can facilitate the delivery into the repair site. The tendon ends may be milked into the proximal to distal fashion, again with flexion, except this time at the wrist and metacarpophalangeal joint. If not completely accessible at this point, a tendon retriever or grasper may be employed. Digits can be visualized in the sheath. The surgeon should be aware, however, that care must be taken while using these instruments, as repeated blind grasping down the tendon sheath may damage the delicate synovial lining of the pulley and provoke adhesions. Additionally, there are two clever techniques which can be employed. First, a skin hook may be used as described by Morris and Martin. The hook end is slid along the surface of the sheet until it is past the tendon, and then the hook is turned towards the tendon and pierced into the smooth superficial one. The instrument is pulled distally with both tendon usually following. The second method is by Sormelis and McGarther. A small catheter is passed from the distal wound into the palm, or vice versa, within the sheath. Through a mid-palmar incision, the catheter is sutured to both tendons several centimeters proximal to the A1 pulley. The catheter is then pulled down distally and freely delivers the tendon stump for suturing. Regardless of the manner by the way you retrieve the proximal tendon, once the tendon ends are brought into the cruciate window, a 25 gauge needle is used to maintain their position without unnecessary repeating grasping of the tendons. Core sutures can then be placed in both superficialis and profundus proximal end to allow juxtapositioning of the distal ends of both. Prior to final repair, it is necessary to ensure that the proper anatomic relationship between the superficialis and profundus is restored. It is worth a second look to verify that, indeed, the proximal end of the profundus lying deep to the superficialis, proximal to the Kemper's chiasm, is matched with its distal counterpart. The repair of both superficialis and profundus consists of 4 coarse strands of 4-0 polyester. An additional running horizontal locking stitch using 6-0 proline is placed in the peripheral epitendonous layer of each tendon. The flexor sheath is not repaired. When the repair is completed, the digit must be pulled through the full range of motion passively extended at the DIP joint. This motion will test the strength of the repair. After the completion of the repair, the lacerated digital nerves are repaired with 9-0 nylon sutures. Occasionally, both digital nerves and one or both arteries need repair as well. The skin is closed with 4-0 nylon in an entrapted fashion. A sterile dressing minimizing pressure between the digits is utilized. The fingers are splinted with the wrist in 30 degrees of flexion. Metacarpopharyngeal joint flexion 45 degrees and near extension of PIP and DAP joints. Postoperatively, understanding the healing stages of the tendon repair is helpful in guiding postoperative management. For day 1 to 3, tendon strength is equal to suture strength. From day 4 to 14, tendon strength decreases with the inflammatory response and weakening of collagen fibrils, the exudative phase. From day 15 to 28, tendon repair and strength begins to increase, that is reparative phase. And passive motion helps convert longitudinal tensile forces to compression across the tendon healing site. By day 28, the active phase of tendon healing is sufficient underway to allow active motion. The Flexor Repair Rehabilitation Program is instituted 2 to 3 days postoperatively. It has been demonstrated that delicate active flexion movement performed with the wrist in extension should be relatively safe for tendon repair, with a 4 or 6 strand core suture technique, enhanced by strong running locking epitendonal sutures. This is the case in our patient as well. The program begins with the therapist instructing him to passively flex over 3 long fingers joints with the wrist maintained in flexion. Then the assistant of the therapist actively extend his wrist while maintaining or holding his digit in the flex position. A resting splint is fashioned similarly to traditional dorsal blocking splint that positions the wrist in 30 degrees of power flexion. the MP joint in 45 degree of flexion and interphalangeal joint in neutral. The splint is removed during therapy to allow assisted place and hold exercises. This protocol is followed for 4 weeks with individual adjustment made depending on the specific problems of the patient that can be encountered, such as excessive pain, swelling, or joint stiffness. After 4 weeks, the repaired tendon should have regained sufficient strength to allow for progression of advancement of therapeutic modalities. Thus, at 4 weeks, active flexion and extension exercises of the digit and wrist are instituted with light muscle contraction. The patient is advised not to extend both the wrist and the fingers simultaneously. The program continues to emphasize the place and hold technique, incorporating passive digital flexion with the wrist flexed, followed by active maintenance of flexion while the wrist is extended. Thereafter, the patient drops the wrist into flexion and extends the digits to commence the tenodesis effect. The dorsal blocking splint is worn between the exercise sessions. At 5 to 6 weeks, more vigorous exercises are permitted involving blocking exercises, isolated tendon excursion activities, and passive extension exercise. A strengthening program is begun at 8 weeks in a gradual, progressive manner. It should be emphasized that the protocol is not for everyone. Additionally, an alternate would be in the event of tendon laceration, non-operative management is less likely an alternative. The consequence would result in patient digits and hand being disabled. Options at that point are still not desirable. The patient would be left with permanent dysfunction and would have to choose surgical intervention. Yet at a later date, the patient options may be more limited, such as a tendon reconstruction or suture amputation of the affected digit.